I'm Dr. Jerry Hesch, a physical therapist. I work at Hesch Institute in Aurora, Colorado. And this is my 300 plus page book on the sacroiliac joint. And I've been actively developing an approach to evaluation and treatment since 1981. And it's certainly undergone a lot of permutation and have followed the research throughout. And we have a very interesting client today who, in spite of the coronavirus flu today, which is March 17, 2020, in spite of the virus, did fly out from Indianapolis to see me. Interesting case in that he did have a right labral tear and had hip surgery that was successful, except that he has some lingering discomfort in the adductor tendon on the right side, and that tendon was stapled onto the pubic bone. He pursued treatment for the sacroiliac and saw a sacroiliac specialist therapist in Georgia, and did how many weeks of stabilization exercises?
It's hard to remember, but at least 6 to 8.
Okay, alrighty. And then after that, this therapist suggested that you needed sacroiliac stabilization surgery, correct?
Yes.
Okay. And then in the operating room, she aligned your pelvis, suggesting that that was necessary for a successful surgery. Is that correct?
That is correct, yep.
Okay. So you did not benefit from that surgery, and they put screws into your SI joint. Was that on both sides?
That was just on the right side.
On the right side,
yep.
Right sacroiliac joint. Okay.
Yes, sir.
So then 6 months later, you chose to have those screws removed.
Yes, sir, that's correct.
Okay.
Yep.
So you do have a little bit of lumbar pathology.
Yes.
That they have identified with an MRI, some stenosis at 2 levels, but no impingement, no disc pressing on a nerve root, even though you have a small herniation, correct?
Right, right.
So you describe that you feel like your pelvis is asymmetrical.
I do, yeah. I feel like everything's just really tight on the right side of my body.
And you felt that way since like 2014?
Yes, several years now.
Okay. And you described on your bicycle that your pelvis feels uneven.
Yeah, on the left side, when I'm, on my sit bones, it feels normal, like it has always felt my entire life riding a bicycle. On the right side, it just felt like a lot of pressure on my right sit bone and some discomfort there. Not excruciating pain, but just something didn't feel quite right.
Okay, alrighty. And in addition to, can you outline where your pain is, please?
Yeah, so in my groin area, like kind of right in here, and the tightness I feel kind of just all in here, and then in my back, really just like right in here.
Uh-huh.
Yep.
Okay.
So those are the major areas.
Very good. And certainly you've done lots of stretching and lots of treatment.
Yeah.
You had 10 visits of chiropractic, and
Yes, sir.
you saw other physical therapists as well.
Yes, sir.
Okay.
For 2 visits a week for about 3 months at the university where I'm attending. So, yeah.
Very good. Alrighty. So you feel like your pelvis is asymmetric.
I do, yep.
And you feel like it's been that way even before the SI surgery.
Yes, sir.
And then when she would do alignment of your pelvis in the PT clinic, did it ever feel like it became symmetrical?
It was hard to tell because if so, the muscle tightness stayed the same, so I never really felt any better or reduction in pain. But I was assured that the pelvis was in alignment at that time. So, yeah, it was a kind of a weird thing.
Okay. How did she evaluate to see if your pelvis was aligned?
Just by checking like the bony, areas that you can visualize with her thumbs, like the right here and on the back, and by leg length.
Okay. Did she, by any chance, evaluate the ischium medially, the sit bones, medially in relationship to the midline gluteal crease?
I don't remember that. Again, it was several years ago, but I don't. That doesn't ring a bell in my head.
Yeah, it's not a standard evaluation in the muscle energy model.
Okay.
The physical therapy community borrowed much of their approach to the sacroiliac from the osteopathic model.
Okay.
And our first article on the SI joint was published in the 70s, late 70s. And the first article in the first edition of Journal of Orthopedic and Sports PT was at that time frame, probably 1980 or 81. Okay. There is more to mechanics of the pelvis than is described in that model.
Okay.
And you have a pattern in your pelvis that's not described in that model. Let's have you lie on your back and I'll demonstrate what I find.
Okay.
In screening your body, I note that you have hyperextension of your knees. I note that your feet hyperpronate somewhat. I notice that your elbows hyperextend a bit. You can extend your fifth MP almost to 90. That's 80 or 85. And the distal IP you can hyperextend. I had you bend forward to try to touch the floor with your palms, but you were about 6 inches away from the floor. So you present as having some hypermobility in your body, okay? Your leg lengths are equal. Your pelvis presents as very symmetrical. And of course, my eyeballing your pelvis is not the same as an x-ray. Okay, I respect that. I was so curious to find out if you had mobility in the pelvis, whether or not it was fused. So I did this posterior springing through the pelvis on the left side, and then we repeated that on the right side. And I was pleased to note that I could load it and I could then spring it. Okay? Your x-ray, or was it your MRI that showed some degeneration in your pubic joint 6 years ago?
I think both, actually.
Alrighty.
Yeah.
Okay. So palpating the very top of your pubic joint, it is symmetrical, and then palpating both sides, coming to the upper third, middle third, and then going down to the lower third, it is symmetrical except when I get to the lower third. And I'm going to move the camera. I don't know if the camera view will demonstrate what I see. But there's a distinct asymmetry down there. So here's a pelvic model, and I'm palpating the upper third of the pubic bones, the middle third, and when I come down here on the lower third, the left one is distinctly posterior. All right, so here I'm on the upper third, and then I'm on the middle third, okay? And then I'm on the very lower part. And if I slide, let me try and get the clothing straight out. If I slide my thumb, I override my left thumb. Okay?
Mm-hmm.
Let's have you lie on your stomach.
Okay.
So you have symmetry of movement with many directions, vertically on both sides, going inferiorly, testing rotation forward, spring on each side, lateral spring on each side, different spring tests on the sacrum all demonstrate good mobility, okay? But then it gets interesting when we come down to the back of the ischium. And your left sit bone, the left ischium, so I'm palpating above the sit bone on this flat portion here, okay? It presents as being more posterior. And this is not subtle. I understand the research. I know that intertester reliability is limited with palpation, but this is distinct. Okay, it's not subtle, okay? And when I do a spring test through the right ischium, I can load I can load it and I can spring it. And this primarily tests mobility through the pubic joint. When I attempt to take up the slack on the left side, it does not load. And if I try to spring it, I'm using more force than I used on the right. What do you feel?
Yeah, I can tell you're trying to press harder on that one. Yeah.
Okay. Did you feel motion on the other side?
Yes.
Do you feel motion here?
No.
No, I don't either. I do not either. Okay? So you can see that if I'm pushing here, that the force translates through the ischium and the pubic joint is right here. Okay? The other thing I note is that when I palpate on the inside of the sit bone and I compare that to the midline crease of the buttock, and the crease of your clothing now matches that, you're very close on the right side. There's about maybe 1.5 thumb width there, okay? And on the left side there is a little more than 2 thumb widths distance away, okay? Now, is this the way your pelvis developed? Or is this a movement dysfunction of the entire pelvis? Well, if I try to induce spring mobility, which all of us have, there is no spring mobility there. And when I try and spring this way, I cannot get normal spring mobility. And I say all of us normals, if you will, and there's no spring this way, okay? And there's no spring this way. So those are the only directions in which motion is blocked going through your pelvis. This is a pattern I discovered in the late 90s, and I named it lower windswept pelvis. Okay? So there's symmetry on the upper landmarks. The PSISs seem very symmetrical. The iliac shelves seem very symmetrical. But when you come down here, there is distinct asymmetry. Okay? So this is treatable, and it begs the question of, is this a movement pattern inside the SI joint and inside the pubic joint? Because of the lower pubic asymmetry, I believe the answer is yes. Okay, you can't have pubic movement without having movement in the sacroiliac joint. However, I think that some of this is also the entire pelvis being shifted over to the left, and I think some of it is in the hip joints as well. We know the SI joint and the pubic joint have very little movement. And we cannot, in the clinic, objectively measure how much movement is happening inside one's sacroiliac or pubic joint. We can only assign a general term such as blocked movement or yes, it moves. Okay, but we can't assign a number to it. This pattern also correlates with a left side bent coccyx or tailbone. And when I pull my index fingers up into the sulcus, you're deeper on your left side. And the tailbone, of course, has the tip, and then it has 2 wings called transverse process on the first segment, first coccygeal segment. So if the tip is side bent over to the left, then there's going to be a deeper sulcus on that left side compared to the right. The other thing I do is I get my thumb on the left side of the coccyx, and I'm going to spring it to the right with a reasonable amount of force. There's no give at all. Okay? And now I'm going to slide my thumb over to the right side of the tailbone, and then when I spring it, the movement translates through that joint and into the rest of your pelvis. Do you feel the difference?
Mm-hmm.
Okay? Very good. I want to show one more motion test on the pubic joint. So go ahead and lie on your back.
Okay.
So I'm on the upper third of the pube, and I'm springing the left side, and there's a little bit of spring. And I'm doing the right side, and there's a little bit of spring mobility. I can actually see my thumb move posteriorly. And I think that you do have a generalized hypermobility syndrome.
Okay.
Okay? And I think that this represents your norm.
Okay.
Okay, I don't think this is pathological. I think this is your norm. But it is interesting that they have determined with imaging that you have degeneration of the pubic joint. And that was in 2014 that they found that. Okay, and now I'm springing on the middle of each pubic bone in a posterior rotation, in a posterior glide direction. All right, and now I'm springing on the lower pube on the right, and I'm doing the same thing on the left. And I feel a little give, and I can see that one side springs a little bit. So that's certainly interesting. So I conclude that you have that pattern which I described in my workbook and in some of my YouTube videos, called a left lower windswept pelvis.
Okay.
Okay. And I have several YouTube videos on this, this being such a unique case since you had a surgery to try to stabilize your SI joint.
Right.
I thought this was a very interesting one to film.
Yeah, for sure.
So it's going to be easy for me to correct it. And what I'm going to do is place a piece of styrofoam underneath the left sit bone.
Okay.
I'll do that for 5 minutes. In my experience, it takes 5 minutes to get a pubic joint to move. Now, you've been doing the so-called pubic adjustments.
Right.
Can you show us how you do that?
Yeah, usually it's at night when I'm laying down and I can tell my groin is bothering me. I'll kind of just put my hands and
Between your knees?
yeah, and you could hear that.
Your knees are bent?
Yeah.
Okay, and then you squeeze together.
Right, and I don't know
And
if you
what
heard it,
happens?
but there's a little bit of an audible pop, and I just squeeze, and then that's usually about it on what I do. Just kind of.
You pointed earlier to where that pop happens.
Yeah, it feels like it kind of happens like kind of low, kind of like right here.
Yeah,
Yep.
so you're lower than the pubic joint. You're on the
Right.
medial thigh.
Right.
And so that's an adductor tendon. And my belief is that that popping is not the pubic joint aligning, even
Okay.
though it feels better.
Right.
I believe that the tendon sheath, the tendon is moving in the tendon sheath, creating a negative pressure and therefore the popping sound.
Okay.
So it's, instead of calling it a pubic adjustment, I call it a tendon adjustment.
Okay. Gotcha.
So I'm going to take this foam
Okay.
and I'm going to place it under the left ischium, and that over the course of 5 minutes should derotate the pubic joint. Okay? And after that, I will work on restoring movement and improving symmetry of position, but more importantly is restoring movement throughout the pelvis, hip, and maybe the SI. And the way that I do that is I want to bring your left ischium medially. I cross over with the right bent knee, and I bring the left leg is straight, and I stretch it over towards me. And I only do that for 2 minutes.
Okay.
Then I traction the right hip and I bring it across outward to the right, called abduction, A-B-D-U-C-T-I-O-N. I do that for 2 minutes. Okay. And lie on your stomach, please. And then I externally rotate the left hip. Okay. After that, I internally rotate the right hip. Okay. Let me go check my camera view. Good. Karen's not here to do the filming, so I'm the cameraman. All right. So after that, we retest position and spring mobility of the ischia. I've never had someone that I could not restore movement. However, sometimes the symmetry improves a little bit, but not fully. And because movement is restored in all directions, then my belief is that in those persons I cannot achieve, symmetry. And we then test them in sitting, and oftentimes we'll prop a 5mm craft foam under one sit bone, and they tend to feel like they have more sitting comfort. feels more natural in sitting because their pelvis has a developmental asymmetry, but the pan of the seat pan is symmetrical. It tries to force them into false symmetry. So anyway, that's how we deal with that. In terms of mobilizing the tailbone, I developed a tool. It's a curved padded tool. And so I apply this onto the left side of the tailbone, and I just hold it with my hand, and then with my thumb I apply a pressure to the right. So I'm pushing on the left side of the tailbone, okay? And I do that for 3 minutes. And then I come onto the lateral ligaments and I push them on the right side of the body. I push them to the right with this tailbone mobilization device for 3 minutes. And that usually is sufficient. It's very unusual for me to have to treat the tailbone more than one time. And I have lots of YouTube videos on side bent coccyx. There's very little in the literature on that. You find nothing on PubMed. But anyway, I've gone on for 21 minutes now, so this is a good time to stop. Very interesting case. Thank you so much for letting us film this.
No problem.
We'll treat it and then we'll come back and film the response.